Primary CNS lymphoma therapy has improved with increasing intensification of first-line chemotherapy, particularly for patients who are able to have high-dose thiotepar and autologous stem cell transplant. However, we're still faced with a big proportion of patients, probably about half of patients in the real-world setting, who will be refractory to methotrexate-based therapy or relapse following treatment. And survival of patients with relapsed or refractory primary CNS lymphoma is very short, measured in a small number of months, and there are no licensed therapies, no approvals, and no standard of care in this setting. So the PRiZM Plus study that we have finished with the recruitment of cohort 1 in the UK, it's an academic-led study, multi-centre, focusing on patients with relapsed and refractory primary CNS lymphoma. We know many of these patients are resistant to chemotherapy, their disease is resistant to chemotherapy. So we've used a novel agent in the form of Zanubrutinib, a second-generation BTK inhibitor, which has really good biological rationale in primary CNS lymphoma because the biology sits genomically at the ABC end of the spectrum with common CD79 and MYD88 mutations. So there's good rationale preclinically to use a BTK inhibitor. And we're presenting the first cohort of data from the PRiZM study, which is Zanubrutinib monotherapy. And this is a really difficult group of patients. Many patients have had autologous transplant. The duration of their first response is short. And importantly, we've included patients who have neurocognitive dysfunction, so they can't have the capacity to consent. And these patients are often excluded from clinical trials, but there's a legal mechanism for including such patients into interventional studies. So we have a number of patients in the PRiZM study who have this kind of dysfunction. And we see response rates of 50%, so an overall response rate from cohort 1, Zanubrutinib monotherapy, 50%, which is a really impressive response rate in this difficult group of patients. What we'd now like to do is to move on to combination therapies, and there are a number of biologically rational combinations with BTK inhibitors that will be explored in subsequent cohorts, and I hope to be able to update you in the future.